Schmoopy! What's your dog's name?
Murray.
Murray! Oh my God, Murray is so cute.
Yeah, he's so nice. He gets really curious when I'm on the phone.
Does he wanna weigh in at some point?
Yeah, he probably does. He's on a little prednisone right now, so he knows a thing or two about nausea and vomiting.
You want to start it off by introducing yourself?
Hello, I'm Alex Manning. I'm a PGY3 in obstetrics and gynecology at Maimonides Medical Center.
We are going to talk about Hyperemesis Gravidarum in the pregnant population in the emergency department. And we see a lot of women in their first trimester in the ED, and it is not uncommon for a woman to come in and say, "Doc, I've been vomiting my brains out for days. I can't keep anything down anymore." The first question I have for you is, can I call this, with that story, can I call this Hyperemesis Gravidarum, or is this just like nausea, vomiting associated with pregnancy?
It's a spectrum, and hyperemesis is at the very extreme end of one. We're cautious with the definition because generally what we want to see is a complete inability to tolerate PO. We generally see ketonuria, and we see a weight loss about 5% compared to pre-pregnancy. Although the hard and fast rule is, if you're concerned about it, you can call it that and label it whatever you want, as long as we treat it properly.
Does it matter what I call it? Does my treatment differ depending on if they're just nausea and vomiting associated with pregnancy versus they are hyperemesis?
So I'd say usually if they're not admitted, it's probably not hyperemesis gravidarum, but it doesn't really matter as long as you treat it and get them feeling better.
I feel like every single one of these patients, when they come in through triage, they're going to have an IV put in. And I know some of the regular stuff to look for in any dehydrated patient, right? Like, I'm looking for an elevation in their creatinine. I'm looking for electrolyte abnormalities, metabolic derangements. Is there anything else specific that you guys are looking for in these patients?
No, not necessarily. It's CBC and a complete metabolic panel is usually what we look at. Because sometimes you can see elements of starvation, and that's mainly what we're looking for. And then as long as you have a mag and FOS in there as well, it's usually very helpful for us.
Someone at some point is inevitably going to draw an HCG on this patient, and it's going to be, however many thousands it is that particular day. Does that matter? Do I care about that? Do you care about that?
No, not so much. Mostly, we want to see a sonogram. That's going to be important. We just want to make sure that it's not, you're more likely to have severe nausea and vomiting if you have multiple gestation. And if you've had it before, that's the most important or the most predictive factor. So sono is going to be a lot more important. You can draw a beta, but if we don't have anything to compare it to, it's very hard as a tool. Is just a single value.
All right, we're moving into the meat of it now. So woman comes in through triage. She's hanging out in the ER stretcher. She looks miserable. She looks dehydrated. I'm going to fluid resuscitate her. And then I or someone will go to the computer and order 4 milligrams of Zofran IV push.
Mm-hmm. And she's going to continue to vomit.
All right, so that's what I wanted to talk about. So what is that not the best idea? Should I be starting with something else?
It's not harmful. We tend in our department to use Reglan more than Zofran. There's no problem in giving some Zofran, but much more importantly is getting other things on board and having those as a standing order as opposed to PRN. What I would recommend is B6 and doxalamine. Or Diclegis is the brand that I don't think we use it in the hospital, but the 2 separate medications, getting those on board as a standing medication. And other things like Benadryl can help a lot. Phenergan is awesome. It works very, very well.
I feel like that was a significant regimen of medications. What's the go-to? What do you start with, and how do you escalate after that?
So we start with B6. B6 has been shown to be really helpful. It really helps to decrease the symptoms and the severity of symptoms. Then we add in doxalamine usually almost immediately. It's tolerated really well and can help reduce the nausea and vomiting. And then we often will use Benadryl almost immediately as well. And if not using Benadryl, then using Phenergan is awesome.
Standing, B6, doxalamine, Benadryl, even potentially if it's bad enough. And then even would you give Reglan standing too?
I would. I mean, depending on their severity, the B6 and doxalamine I would have standing for almost any patient that walks in the door with symptoms like this. And then Reglan and Benadryl, I would work it up to standing pretty quickly based on how well the B6 and doxalamine controls it.
If the knee-jerk response in some way is to be like, this lady needs B6 right off the bat, plus or minus doxalamine, is there any reason I shouldn't be reaching for that for every nauseous and vomiting pregnant patient that comes in, and make sure that she's getting a script to go home with?
No, there's no reason not to, but is really expensive and it's not covered by a lot of insurance. So almost always when we're prescribing it in our clinic, which tends to be underserved women, we do it separately. We do pyridoxine and we do doxalamine, because you just take 2 pills in the same effect. We often have the situation where they can't afford it. They don't call and let us know that their insurance doesn't cover it, and then they get worse because they haven't been taking anything. Other things that you can point out is if the patient should definitely be taking folic acid. It's very beneficial. It's more helpful when you take it prior to conception, but it's still something we want to encourage in early trimester. So if they're really not tolerating and they can't hold down prenatal vitamins and things like that, giving them B6 and then making sure that they're taking their folic acid is also a really good alternative. And also I really highly recommend a lot of other treatments too. So like ginger tea, making sure that their timing of their meals, small meals, frequent meals, and not waiting. So the issue is if you wait until you're nauseous, it's very hard to scale it back. So that's why we say, take these medications standing at least for a few days, eat a little something regularly, even if you're not hungry yet, but having an empty stomach is going to make your nausea and vomiting worse. And once it gets going, it's harder to scale it back.
Would you ever tell someone when they go home that, okay, if you're taking your B6 and you're still feeling nauseous, you should try some PO Benadryl?
Yeah, absolutely. I would definitely tell them to take PO Benadryl. Oftentimes, we're seeing young, healthy, reproductive age women. They often have small children at home. So I will tell them to start the Benadryl. When you do take it at night, because it's going to make you feel drowsy. That's part of the way that it works, is if you're tired, you're not thinking about how nauseous you are. But definitely, it's a really good option and safe to take.
So speaking of safe to take, should I be worried about the fetus in any of these medications that I'm giving?
So Zofran, there is an association with some sort of adverse fetal outcomes. It's a very loose association, but and hasn't really bore out yet in the evidence, but it's powerful enough that lots of OBs shy away from it if we can manage their symptoms with other medications.
Of the patients that end up admitted to the hospital and you look back on their chart, is there anything you want to relate to the ED that you're like, oh, we could have done this and we could have potentially saved an admission for this lady?
What we often see, which is a point of frustration for us, is that by the time they come to us, they've often been in the CDU for quite some time and they haven't been getting the medication standing. And then the patient themselves feels like, I'm never going to feel better. When in actuality, if we had given it a standing medication and caught the nausea before it gets severe, they actually probably could have gone home rather than being admitted.
Thank you, Alex. I appreciate it.
No problem. Thanks so much, Duncan.